Hey, everybody. Welcome. Welcome to our first MS Views and News program to this portion of Maryland. For those that don't know, my name is Stuart Schlossman, and guess what? I'm a peer to those with MS, because I too have MS, right? Thank you. Yes, I remember that too. So again, my name is Stuart Schlossman. I have multiple sclerosis. I was diagnosed back in '98, all right? And, after a few years of seeing what people are not getting as far as educational programs, we decided that we're going to form this organization and provide this. We're now providing these programs in 22 states. Okay, and last year we did 53 programs, and this year we're set to do 53 programs as well. So, in order to thank the company that's responsible for giving us the funding to do tonight's program, I want to thank Teva Neuroscience, and I hope you all can thank them as well. Say thank you, Teva. But first, whenever we go to a new area, we ask support group leaders to come up and speak for 90 seconds about their group. So right now we have Dulcie Hill. Okay, she'll introduce herself, and she's going to tell us about her group.
If you have MS, you should write down this website, msfrontiers.org. MS Frontiers is a peer support organization for people with multiple sclerosis, by people with multiple sclerosis. Who better to assist people with MS than people who have MS and have had the same symptoms, fears, and treatments and frustrations? We share diets we've tried, supplements we use, exercises that help, emotional support when we feel misunderstood. MS Frontiers support group started as a private Facebook group that was created to gather curious people together to analyze and discuss the meaning of the latest studies and research. Over the years, MS Frontiers has evolved into a multiple sclerosis medical support group. This made it possible for each member to recruit the collective members of the group to be part of their MS management team. Each person who joins becomes an important member who may have questions about a symptom, a test, a medication, a side effect, or a treatment option. Or that person who joins can offer to answer questions to other people who have questions based on their own experience. Our medical support groups have approximately 2,500 members with MS. Each with an average experience of 10 years. That is 25,000 years of experience with multiple sclerosis. It is incredible. It's critical to note that this information that you get there, or the suggestions you get, is based on what has worked with people through their own experiences, but should never take the place of your doctor. The suggestions are there for you to discuss with your doctor and evaluate. So again, write down the website, msfrontiers.org. I have a couple cards for people who can't manage to write it down, and thank you for letting me share.
Thank you, Dulcie. That's great. Next up, Dr. Crayton. Would you like the podium? Thank you again. Thanks for coming down here today.
It is a pleasure.
Thank you.
Good evening, everybody. Can everybody hear me okay?
Yes.
Never been accused of being too quiet. I don't like to hold a mic because I like to walk and I like to use my hands. Am I going to be able to, I guess I really can't roam, huh? I guess I should kind of try to stay put a little bit. It is a pleasure to be here. Stuart gave me quite the to-do list for tonight in terms of what I'm supposed to be covering and topics. And I kind of decided to go completely rogue and not put together a boring PowerPoint. I do PowerPoint slideshows all the time, and I just didn't feel like it. So I'm going to just talk, and this is very hard for me to stand in one place. I am such a roamer because I try to move. Jeff says you have to move. I move. I can move here.
Yeah.
Wow. Yay me. So just to tell you who I am, I'm an MS neurologist. All I've ever done as a neurologist is multiple sclerosis. I think neurology is really pretty cool, but I think MS is way, way cool. There is truly no more exciting time than right now if you have MS. MS is really just an explosive area of neurology right now. And really within neurology and neurological conditions, there is the most growth in terms of MS. We have 14 medications on the market right now and many others in the pipeline. So there's really a lot going on with MS. It used to be that people who went into neurology, just to kind of give you a little bit of insight into the mindset of the typical neurologist, people who typically went into neurology used to be the brightest in their medical school class. They were cogitators, pontificators, studiers, observers. There's a lot of history written about MS. There's a lot of history written about neurological conditions because typically people kind of considered neurology more of an observational specialty. And you observed people as they were having seizures or strokes. You wrote about it, you described it, you drew pictures of it, but you sure as hell didn't do anything about it. You watched. So this has changed dramatically, and it is, I think, sometimes a little disruptive to people that have that original mindset, that neurology is something that you do when you're not an adrenaline junkie, that we just kind of observe and watch because there's not a whole lot that can be done. When I was going into neurology, I decided as a third-year medical student to be a neurologist. I really, really dug the whole puzzle and kind of trying to trace things back to where the problem was. And my colleagues would say to me in medical school, I can't believe you're going to be a neurologist. And when I went into MS, my neurology colleagues within my department even said, I can't believe you're going to do MS. Who would want to do MS? There's nothing you can do for those people. And I still, when I see general neurologists, they say, oh my gosh, all you do is MS? And I say, all you do is headache? So I think it's incredibly exciting, incredibly cool, and there's really so much that can be done. It can be a little daunting, though, for somebody, a neurologist who doesn't do a lot of MS. And you need to understand that. So one of the tasks I have tonight is to talk about kind of getting what you want, being the best consumer that you can, and really having a successful partnership and path of communication with your physician. This is really important. It sounds very common sense, but it is really, really important. And I like to use the analogy that people with MS really need to shop. You need to look at reviews. You need to hear what other people have to say because it's your responsibility to find somebody that you can really communicate with, you can work with. People spend more time shopping for a mortgage or a car loan than they do a physician. And you're going to have MS for a long time, and if you're not moving, if you're living in the same area, you kind of need to find somebody that you really like working with. You got to be able to lay it all on the line. You got to be able to tell them everything. I say to my patients, I will work my ass off for you, but you better come halfway. I'm not the appropriate person to see if somebody wants to be told what to do. Some people, you have to kind of know, are you somebody that wants to be told what to do, or do you want a partnership? Do you want to engage? Do you want to have some participation in that process? I think that's way more exciting than to just kind of sit back and do what you're told to do. So part of successful existing with MS, after one comes around to accepting this diagnosis, which we do a pretty lousy job of helping you through that part, once you get to the point of understanding that you can handle this and you kind of become more comfortable in your skin, it's important that you have the team of people around you that supports you. It's important to have the doc that supports you. It's important to have therapists. Sometimes that's a little bit hard to find. Physical therapy that really understands what your needs are, who have kind of a neurological understanding. It's important to find a support group that you really, really fit into and that you really like. I think that's really important. I think support groups are really important. As much as I care about my patients and as much as your family members love you, nobody knows what it's like to have MS unless they have MS. So nobody knows what it means to wake up and say, I feel MS-y today, unless they have MS. I can throw out a lot of adjectives, what I think that means, besides just crap. But I think it's really important that people understand what it's like to be in your shoes. So I think that that's really, really important. I hear oftentimes people, especially newbies, don't really want to go to support group because they don't want to see what MS could look like. And I think more than that, the issue is that you need to find people of like ilk. I don't think it's appropriate for somebody who's just been diagnosed at 20 to go to a support group with a bunch of 50-year-old women that are empty nesters that are talking about freedom because kids are leaving. Somebody who's 20 wants to know, gosh, do I tell somebody on the first date? Do I wait till the third date? Should I not even think about dating? Can I have a family? People have totally different needs. Men have totally different needs than women. So again, to have a bunch of guys in a room with, or have a couple of guys brave enough to venture out into a support group meeting with a bunch of women that are talking about, needs of a 50, 60-year-old woman, it's a little daunting. So I think that it's important to find that group that supports you and that you feel good with. And I think that whether you can find that on your own or you need help, I think that's really important. In my practice, I like to kind of, when people are newly diagnosed, I usually try to find somebody like them to kind of show them the way a little bit, and then I pluck away their newbie card and I say, now it's your turn to be a mentor to somebody else. If it's somebody who's, a young male, I try to, young African-American male, then I try to find another young African-American male or Hispanic. If it's a young woman, I try to hook that person up with another young woman, kind of their age, kind of in the same place in life, because that's really important. Sometimes I do like to pick somebody who's old like me for a 20-year-old to say, but this is what you have to look forward to. I digress. I have a nurse who works with me who's my patient. She's a nurse in my practice, and she's had MS for over 10 years, since 1992. She's been my patient for quite some time, and she's always my ace in the hole, because I can talk about MS, I can educate, I can tell people about what to expect, and they say, yeah. But then I pull her in, and I say, that this person over here that you thought was just my nurse, she has MS. She's had MS a really long time. She's the mother of 4. She's certainly thinner than I am and in far better shape than I will ever be, and does things that are not even close to being on my bucket list. So she's an inspiration for me. So I think that that's important as well, to kind of show people what the future can hold. Everybody has expectations of life. And when you're giving these 2 letters, everything kind of falls apart. And again, we don't do a very good job of bridging people across that great divide between what you thought your life was going to look like and what it all of a sudden is going to look like as of this day going forward. When somebody's told that they have cancer, the nurses are there when you come out of the room, arm around you. They tell you about support systems that are in place. They tell you that there's this whole community. They totally take care of you. When you have a lot of chronic conditions, it really, really makes me angry when a physician kind of spits out very haphazardly this diagnosis and then wants to shove this whole bag full of medicine stuff in somebody's hands, and then has the nerve to say, go home and look at all these zillions of things that are options for you, and then you let me know what you want to do. The person is still stuck on, I have what? This happens all the time. Of course, all of you have allowed this to happen as well. You would never accept that in any other area of medicine. If you were told you had cancer and somebody said, go out on the internet and kind of check it all out and tell me what kind of cancer therapy you think is best for you, I just don't think that would be okay. I'll take it down a notch into something less serious. If you had hypertension, diabetes, and the doc said, okay, I want to give you this diagnosis, and there could be fatal outcomes. I mean, diabetes and hypertension are stroke risk factors. There are a couple different things you can do for it, but I'm going to kind of let you check that out yourself, and I'm going to let you kind of read up on that and look through those studies that are out there that kind of talk about the various products that you can have access to, and then you let me know what you want to start. You'd say, but you're the doctor, I'm the patient. But somehow this is kind of continuing to play out in the MS world, and that needs to stop. It is your responsibility to demand more of your healthcare team. You need to come prepared. I love what Stu was talking about with that little tool to be able to bring to your healthcare team when you have these appointments. It's really important to remember that that is your time with your physician. You are the client. You are the person who is in charge of that appointment, or you're supposed to be. Don't let any physician or any healthcare provider kind of run away with your agenda and railroad you. Yes, we have our agenda, and we will take away anything that you brought as your agenda if you don't really seize the moment and take a hold of the appointment. So it's important for you to know your MS. You have to understand the good, the bad, the ugly of your MS. You have to know what bothers you and what doesn't bother you. You have to know what your symptoms are. Sometimes when I ask people what their symptoms are, they're kind of dumbfounded. They say, well, exactly, like, what do you mean? I live with that stuff all the time. And I say, but can you kind of break that down for me? Because I'm in the job of trying to kind of fix it, but if you don't really know what needs to be fixed, I kind of can't even work on fixing it. So it's important for you to know what kind of symptoms you have from your MS, if it bothers you, and if it bothers you, when it bothers you. I always use the example of spasticity because I've really made quite a few mistakes in treating people that didn't necessarily need to be treated or want to be treated for particular symptoms. Couple of examples. I had a woman who I started seeing at Georgetown years and years and years ago, and she was essentially, she was confined to her power chair. She really had very little movement of her upper extremities and no movement in her lower extremities. Her husband did a lot of help, did a lot of care for her and transferring, and her legs were incredibly spastic. And he said, yes, when I have to transfer into the car to come to appointments and things, I had to put my whole body effort into bending those legs that just want to stick straight out. And I thought, I can be the big hero. I'm going to aggressively treat this woman's spasticity so I can feel like I'm doing something. So a couple months later, they come back for an appointment. They were both really not nice. They were incredibly PO'd at me. And they said that I had made her more disabled. And I was shocked. I said, how could I have done that? And they said, because you treated her spasticity so well that you really took away tone that was needed to help her participate in her transfers. So before I started monkeying around, he was able to pull her up out of the chair. She was able to lock her knees. She had enough tone. She was really spastic, and she used it wisely. And she could pivot and plop. So I came along to be the big hero. I aggressively was treating her spasticity, put her on lots of medicine, lots of baclofen. So when he lifted her up, her legs were like noodles, just wet noodles. And she was dead weight. So he came in saying, I'm a problem now. She feels defeated. I just screwed up the whole dynamic. And that's when I learned to ask permission to treat people's symptoms. And you need to know if you have a symptom that bothers you. If it bothers you, when does it bother you? If you want it treated. If you want it treated, when do you want it treated? Because we're in the habit of trying to fix, and I see people come in who are on this whole list of medicines, and I say, what do you take that for, and does it help you? And people are so lost with the list, they say, I'm not really sure. I'm not even really sure exactly why I'm taking it, and I'm not really sure if it helps me. Okay, well, you're on 10 medicines. It's the same as really having an idea and a handle on what is going on with your MS. When I treat people for fatigue, I say, when are you fatigued? When is it a problem? Is it all the time? Is it every day? Is it mostly in the morning? Is it that you peter out at the end of the day? Because if it's an end of the day problem, why would I waste medicine medicating you in the morning if you don't really need that? If you're spastic at certain times, let's use those times to focus on treating you. Is your bladder a problem? Some people say, I don't care that my bladder wreaks havoc and totally runs my life during the day because it allows me to move. It's the only time I get up a lot, but at least I'm getting up. But at nighttime, that's a no-no. We don't need that at night. So sometimes then I'll just make it stop at nighttime. So it's important for you to understand if these symptoms are an annoyance to you or not, and if they need to be treated or not. That's really important. So knowing what your MS is all about, knowing about your symptoms, even on the very best MS medicines, people usually still have symptoms. Medicines that we use for MS typically don't make our symptoms go away. They just kind of keep you more stable. And it's important to be engaged and communicate about these problems that you want addressed. So this navigation tool is really, really important because in this day and age of medicine, things are very, very quick, very, very fast. You have short amount of time with your healthcare team. 15 minutes, 20 minutes. Sometimes it may take that long just to kind of get you in the room and get you kind of situated. And you have to be prepared. You have to be a wise consumer. You have to be prepared. Please know your medicines. Let me just tell you. Let me just stop being formal. Docs will talk behind your back about a lot of stuff, and they're talking about you. And there's some people that when it's time for you to come to the office and it's your appointment, everybody in the office knows you're coming and they're talking about you. They're saying, is that person who brings that 3-inch binder every single time they come? And we say, oh, God, help me. Is that a 4 o'clock appointment? Is that the person who knows nothing about their medicines, I'm going to have to open up the PDR, the drug Bible, and go through every single medicine with them because they're going to tell me that they're on the little red pill for this, and they're on the little purple pill, and then they're on this little house-shaped pill that they take, a couple of times a day. They're not sure exactly, and then they're on a bunch of supplements that they will have absolutely no idea what they are. Yeah, that's the one. That's the one who's coming here. Let's brace ourselves. Please be prepared. And for God's sakes, if you've had a surgical procedure, you better well know what organ was taken out of your body. Because I can tell you right now that doesn't always happen. What do you mean you had surgery? What'd you have surgery for? Well, they said I needed surgery. Surgery for what? Where's your scar? Well, it's over here. So what'd you have taken out? I'm not sure they took anything out. It may have just been, like those robotic tools, looking at stuff. So please know your medical history. Please know that if somebody cut you and took out a part of your body, what that part of your body was. When you're on medicines, please know what those medicines are for. Please know who prescribed those medicines. Because don't ask me for a refill of your hypertension medicine or your Synthroid when I'm not the doctor that does anything with that. Be prepared. It's always really, really nice to have somebody come with you to these appointments to kind of help you stay on track and to be another set of ears. We all need another set of ears. And I can tell you, men, if you don't have that woman with you, then you better be recording the whole appointment. Because women can tell me just about every detail, because women know the exact day, time that they were diagnosed. They know what the weather was like that day. They can tell me when they started their medicine. They know the date. They know everything. So then there's the appointment with the guy who comes by himself. We do talk about that too. We're like, oh God, put a fork in my eye. So the gentleman that comes by himself, we say, how are you doing? Everything's great. everything's great, doc. Okay, so do you have a problem with this? Do you have a problem with this? How's your bladder? My bladder's great. So your bowels are good. Oh, perfect. Walking's good. Sensations good. Everything's, things are really good. Oh, okay. So this is how it kind of plays out for a couple of appointments. And then there's that appointment where the woman shows up. And that's a totally different appointment. So in my office, I'm sitting at a desk, and then there are two chairs, and the patient is sitting in the chair next to me, closest to me. And the person who accompanies the patient is sitting in that other chair. And that's when all sorts of fun happens. There's the gesticulating. There's the eye rolling. There's the look of shock that I see in that person sitting in that seat. And then the woman says, so, he's told you about this and this and this, right? And I say, no, this is the first time hearing about that. Oh, well, I have reminded him several times to talk about that. And has he told you about this really embarrassing moment that he had? And has he told you about when he tripped, and he had a fall? Did you know that he had to go to the ER? Oh, no, he failed to mention that to me. So it's sometimes very, very nice to have somebody just kind of fill in the blanks a little bit, because we can't really tend to the things that really need to be tended to unless you bring these to our attention. But guys, let me just say right now, you're the worst. Just the worst. Like pulling teeth. Be honest, because if you're not honest, it can't be handled. My mentor, I learned MS from a really, really great mentor. And everybody loved this man. He's incredibly brilliant, but incredibly wonderful bedside manner. And people loved him. So when he passed me the baton and I took over his practice, I started hearing a lot about bowel and bladder issues. And I thought, is it after like a certain period of time that people have MS and then everybody all at once has bladder and bowel issues? Because I don't recall really, when I was shadowing him, people never really talked about this. So I met with him and I said, everybody in your entire practice has bowel and bladder issues that are kind of just coming out of the woodwork. This is all we talk about. I said, does this happen after a certain amount of time of having MS? Is this something I kind of failed to learn when you were teaching me about MS? And he said, no, I really don't know what this is about. So then I started asking people. Everybody loved this man so much that everybody really across the board, men and women, said, I could have never told him about that. Oh, I've had that for years. I'm incontinent. I have to think about bathrooms everywhere I go. Oh, but I would never talk about that with him. We talked about, football, and we talked about things that were important. So I was faced with a lot of bowel and bladder issues. I'm a mom. Sleeping and pooping are probably the two biggest things that have the biggest impact on your life. If you're not sleeping, it's all bad. All bad. You're bitchy, you're blue, you're weak, you're tired. It's all bad. It falls apart. You're an emotional wreck. It's all bad. And if you're not pooping, let me tell you, life is bad. And nobody poops because you don't want to drink because you don't want to pee. So that has to be addressed. And I usually, knock people back and put water down them, we are definitely the water, we are crazy about water in my office because it is the root of all evil. Everything below the waist is connected. When you have a full bladder, you have full bowel, your legs get very spastic. They can maybe get a little weak. They get really wonky. You get a lot of funny sensations. It's all bad. So there are a lot of things that are very connected. I had a guy, speaking of kind of spasticity and treating symptoms, another person who told me I was not allowed to touch his spasticity. He was he's a big guy, walked with forearm crutches, an attorney, and had really no feeling below the waist. So he did not know when his bladder was filling up. The only way that he knew his bladder was filling up was because his legs would get extra tight. And then he knew, ooh, I better get up from this meeting. I better get up because my legs are going to thwart me now. They're going to stiffen up, and it's going to take me double the time to get to the bathroom. But at the first sign of that stiffness, he would get up and start making his way to the bathroom. He said, if you take away my tone, if you take away my spasticity, I won't know that I have to pee. So don't touch it. And he was in tune enough to be able to understand how that was working for him and help him. So it's your responsibility to be a wise consumer, to be educated. I love when I do patient programs to see people out to want to be educated, to want to hear about different medications, different things that are on the market, that are coming down the pike. It behooves you to understand these things because there are some choices that you need to make. There are so many therapies now that it's important for you to know whether you're comfortable and satisfied with the product that you're on or whether it negatively impacts your life in any way, because gone are those days where there were no choices and you were only stuck with medicines that made you feel worse than your MS. Those days are over. And if you are still in that rut, then you need to kind of bring yourself into the modern day and age of MS treatment and look for something different. It's important for you to understand that as we increase benefit, we increase risk. Doesn't mean that all those things we used initially were not with risk. When I hear my colleagues say that, oh, I like to use all that, the injectables, I want to use things that have been around a long time because they're safe and they're not risky. That's not really accurate. Everything has risk. Aspirin. A lot of people die from aspirin every year. It's available over the counter. You can take as much as you want at home. Nobody's watching you. Coumadin. Coumadin's rat poison. It's how Coumadin became something that we could take at home. A lot of people die. A lot of people abuse it. Some, older people wobbly. They fall. They hit their head. They bleed. They die. Everything has risk. And with benefit, increasing benefit, we have risk. So when somebody comes to my office and says, first of all, my favorite, because all of you said this one, I don't like to take medicine. If I hear that one more time, I think I'm probably just going to explode. Duly noted. So what? Move on. There are a lot of things that are out there that you need to understand the benefit of, and you need to understand the risk associated. But you also need to be able to ask, what are you going to do to manage the risk? Risk always needs to be put into perspective, and it's your responsibility to ask, okay, I understand these risks. I've gone to programs, I've learned online, I've done my own research. I understand what the list of risks are, but what is your plan? Doctor, nurse practitioner, your healthcare team, what is the plan to keep me safe? That's what you want to know. You can find risks all over the place, all over the internet. You want to know, what is somebody going to do to help manage that risk and help keep you comforted and know that you're safe? That's what I would want to know. You want to know if somebody's recommending an option for you, a treatment for your MS. You want to know why they've chosen that particular product, because we have so many. You can ask that question. I think it's important for you to understand why somebody is recommending a particular medicine. Because oftentimes what happens is you ask about new medicines at the end of your appointment when it's finally time for your agenda. The doc has done their thing, and then they're looking at their watch. And then you say, but wait a minute, I have my agenda. You pull out your notes. If it's more than a half a page, we're talking about you. I just wanted to let you know. And you're saying, so I know there are a lot of new medicines out there, and I'd like to talk about some of those medicines. I can tell you where that's going to end you. It's going to wind up being, you're fine, you're stable, stay put, gotta go. If you have kind of done a little bit of homework, a little bit of research, a little bit of investigating, you're on a shot, let's say, and you say, you know what? I don't like it. I want something different. Can we talk about, the oral medicines? I've been to a couple of programs. I've kind of heard about this and this and this. Is there something that you think would be good for my kind of MS? You'll get a lot more traction out of something like that than hey doc, can you start from scratch at 5 o'clock on a Friday and tell me about all the medicines? So it's really kind of about manipulating a little bit, manipulating your appointment to get what you want out of that appointment. Let's kind of put that there and move that off to the side. And let's talk a little bit about treating MS. Treating MS involves 3 different pathways at different times. One is the disease-modifying therapy, the goal of which is to decrease the frequency of relapses, decrease MRI lesions, and stave off physical change, the accumulation of physical disability. Then we have symptom medicines, and like I said before, you can be on the very best MS medicine, but still need some tweaking and tuning up of your symptoms. Fatigue, bladder urgency, spasticity, tremor, whatever. And relapse therapy. So even when you're on good disease-modifying therapy, we're not there yet where we can prevent everything 100%. So you might still have relapses, and that's where we use steroids. So people can be on anything from any of those 3 categories at the same time. When it comes to disease-modifying therapy, we have quite a few products on the market that it behooves you to understand and know about. But it's the symptom management that really, really, I think is important. It's important for how you live and how you're able to deal successfully with MS. Because frankly, I don't think that everybody really cares if they have one new spot on their MRI over a couple years. I think what you really care about is, do you have enough energy to be able to get through your workday, get home, get through the dinner thing, and then the whole homework thing and all that evening stuff, that whole other job that happens at night. I think that's probably a little more important to you than whether you have one spot on an MRI scan. I think it's important that you know that you can drive from point A to point B without having to pull off and go and find a bathroom somewhere or panic about a bathroom. I think that's kind of an important thing. I think that making sure that people have the right enabling equipment is way more important to keep you safe, to keep you, out and about and moving. So those are the things that I think are really, really important to your living successfully with MS. And I think that sometimes does not get really tended to, and it needs to. But you have to make sure that you bring that up. Because there's lots and lots and lots of things that we can do to enhance the quality of your life and minimize your symptoms. A lot. We can help you deal better with the heat. We can help you really deal with a lot of issues that really do impact your quality of life. Because even, again, when you're on the very best disease-modifying therapy and your MS is totally stable, you still have these things, this constellation of symptoms that is always there, that you always have. Which is why many people think that they have progressive MS, because they say, I have stuff always there, and relapsing, remitting means, like cancer, remission means gone. And so I must have progressive MS because I have symptoms all the time. That's not the case. We just have a little weirdness going on with the nomenclature. I think too, that word remission means gone. In cancer literature, it means gone, no evidence of. It's not there. I'm not sure why we use that term. Because I know very, very, very few people that have 0 reminder of their MS. Very, very, very few people. Everybody knows they have MS. Everybody has their little constellation of things that just follows them around everywhere they go. You know, you're a different person in the beginning of the day than the end of the day. Many people are kind of, really starting to kind of, everybody's awake. This is beautiful because we have the drop-off time. You're a different person at the beginning of the day than the end of the day. You're a different person today than you're going to be tomorrow or than you were yesterday. So that's really, really important to remember. We need to sometimes tweak things according to how you feel, how you're going to feel. But those baseline constellation of things sometimes are your barometer to keep you in check, to let you know when you're overdoing it, when you're burning the candle at both ends, when maybe your sleep is not so great and you're thinking, I can deal with that 4 or 5 hours every night. I can do that. Then you wonder why everything's numb and tingly and your balance is a little wonky and things are just not right. So sometimes that's your cue to say, oh yeah, I guess I kind of have to pay attention to my body. But for most people, there's something that is there all the time to remind them that they have MS, just in case you might forget. So you don't have progressive MS just because you have this constellation of things that just hangs around with you all the time. Most people have that. Again, it's incredibly, incredibly, incredibly rare for people to have zero reminder that they have MS. So keep that in mind. We've kind of talked about communication. We've kind of talked about partnering with your healthcare team. The medicines, I'm just going to touch on a little bit about the medicines. You know, we have these categories of medicines now. Some of them are incredibly sophisticated. When we had the injectable medicines, we used to kind of, there was a paragraph to talk about the mechanism of action because we were never really sure. We'd say, well, I think it kind of does this, and I think it kind of does this, and we think maybe this, and it's like a paragraph. Now it's really more of a sentence with most of our therapeutics because a lot of them are designed with a particular function in mind. So they are designed to do a particular job. So we have the injectable products, which are lower efficacy. We have the oral therapies. We take a step up in efficacy. And then we have IV medicines, the monoclonal antibodies, which are kind of felt to be the ultimate in terms of efficacy. And as we have increased in efficacy, we have certainly increased in our risk profile. Again, everything has risk. It's about what the risk mitigation strategy is going to be. It's about whether being on something more effective can do more for you. Not every medicine is for every person, and if people are really completely stable, and that means a lot of things, then they're probably okay where they are as long as it doesn't impact their lifestyle and quality of life negatively. If it does, it's time to move on. I get chided by my colleagues because they say, you're willing to change somebody's medicine even if they're stable? And I say, yeah, if they feel like shit, they feel like shit. It's time to move on. But they're stable. Yeah, but do you know what it's like for them to experience that medicine at home? You know, stable means what? And then when people are really pressed, because I have some docs that I visit around the country that say, my practice, my patients are so stable. They are all doing so well. And I say, wow, that's just amazing. That's really great, but that's really amazing. What are your criteria? They still work. I had somebody recently say that to me who's a pretty important MS person. And of course that did kind of get my dander up a little bit. I'd only had one glass of wine that night and I wasn't quite as calm as I probably should have been. And I said, wow, so they work. That's a pretty low bar. Is their life at home good? And, well, you know, I don't know. I don't know. Are they cognitively okay? Well, yeah, they're working. So stable to me means that somebody has nothing new to say, that their MRIs do not change, and their exam does not change. There are 3 criteria to being stable. And regardless of whether my exam is stable, if people continuously talk about change, then that's not stable. Because ultimately the person who's living in the MS body knows a hell of a lot more about their MS than I do. So you have to keep that in mind. So it's important for you to understand whether you feel that your MS is stable, whether you want more, whether you think you can achieve another level of change, and discuss that with your healthcare team, and then discuss risks and benefits. But I think that is your responsibility to ask, is this particular newer product beneficial for me? Is it something I should be considering? Why or why not? Because maybe the answer is no. I mean, I tell people no. I like where we're at. I think that where you're at is a good place. But you need to have those questions answered because there's a lot of choices out there, a lot of opportunities for change, and a lot of opportunities for improved status, whether it's change in disease-modifying therapy or tuning up your symptoms. There's a lot out there. I am going to take a break from talking because I can talk about MS until midnight. Nobody wants that. And I'm going to ask for questions about anything that I may have said or should have said first.
So firstly, thank you for everything, because that was way beyond perfect. All right, that's number one. Number two, I need to run around and get everybody to talk to the microphone when we have to do this. So if you could just raise your hands, and I'm going to go around the room and I'm going to show you this. I need to put this in front of your face so that way when we're people watching that they can hear what you're saying, okay?
Thank you, Stu. You were wonderful. You were wonderful. First question I have is you talked about people feeling yucky all the time and it not being progressive.
Medical term.
Right. And it not being progressive MS. A lot of people who've had MS for a long time are progressing. Can you tell us what is the definition of progressive MS and how is that different from having relapsing, remitting MS and feeling yucky?
Great question. Nobody's ever really asked me that in that way, and I think that's a great question. So, we have these categories of MS, and that's one question I don't like people to ask me, my own patients, what kind of MS do I have? You have your kind of MS. MS is really, I believe, a spectrum, and people kind of fall different places on that spectrum. We have these categories which make it easy for us to pigeonhole people for clinical trials, frankly. So when we talk about relapsing remitting MS, we're talking about people having something new that lasts for a couple of days or longer, or an increase in those baseline set of symptoms that you've come to know and love. So things that you have all the time can escalate and persist for several days and then quiet down with or without treatment. So that's relapsing MS. Progression is typically noted by kind of slow, insidious change without having a frank relapse. So when I say to people, are you different than you were 6 months ago? And people say, oh yeah, I'm changed. I'm different than I was 6 months ago, and I can't tell you when it happened. Versus, yeah, I've been really bad the past 2 weeks. Very different. If somebody, I usually ask two questions. When I see people for the first time, I ask, are you different than you were 6 months ago? Are you different than you were a year ago? And I ask the person I'm seeing as well as somebody who's accompanying them. So I can know what the slope of change is. Everybody is fearful of that P word, the word progressive. I can tell you that relapsing remitting MS includes people that just have rip-roaring, fiery, inflammatory, off-the-cliff MS. Those people that have such deep drops and they have to work so hard to come back, and they have relapse after relapse, and they're devastating. They are completely disabling. That's relapsing remitting MS. Versus a gentleman I saw years back who said, I have progressive MS. I read about these things called relapses in the magazines and stuff, and I don't know what that is. I never had anything like that. I can tell you it has just kind of continued from onset. I said, have you changed in the past 6 months? He said, no. Have you changed in the past year? No. He said, I've changed over the course of 5 years. In a heartbeat, I'd much rather be that man than that person who's relapsing remitting. So you guys have to kind of get over the labels and that terminology. It's what kind of MS do you have? Do you have, loud, inflammatory, aggressive MS? Do you have a lot going on? Do you have incomplete recovery from relapses? Do you have things happening over and over and over and over? We don't like active MS. We don't like that. So highly inflammatory MS we don't like. But sometimes when people are pigeonholed and kind of put into that category of being progressive, lo and behold, they'll have a relapse. And what do you do with that? They've been pigeonholed so nicely. They haven't had access to medicines because somebody's documented all throughout the chart that this person has progressive MS. Or sometimes you do an MRI scan and they have enhancing lesions all over the place. So what does that mean? They're inflammatory. They're people that need to be treated. So, not a very simple answer to your question, because we should really not be thinking so much about these little pigeonhole categories. Does that make sense?
It did make sense. However, I was specifically talking about when relapsing remitting goes into a secondary progressive.
Goes into. So when somebody started off having frank relapses and knowing, yes, it started this day or this week, and then can no longer say that. That's that kind of transition into having secondary progressive MS, when you say, yeah, I can't really tell you when it happened, but I'm very different than I was 6 months ago. Christmas shopping this year is going to mean a lot more online and really not going into the mall, whereas last Christmas I was actually willing to venture into the mall. Next question.
You talked about, whenever you're first told that you have MS, to really be your own advocate and kind of pursue that. Like, you wouldn't just take that cancer diagnosis and let them just walk out the room. Well, that's what happened with me. And I was in the hospital, and a doctor walked in and said, "You have MS, so I'm going to have the nurse get you some paperwork," and walked out.
My apologies for the medical community.
But I guess that's the question is whenever a doctor walks in and gives you that, you don't even know what to ask or say, or like, I had no idea. That was the last diagnosis I was expecting.
You don't know what you don't know.
Right. I had no idea. I didn't know if that meant I was going to die. I didn't know if that meant I was going to stay the way I was in the hospital. I had no idea what to ask. And so it sounds like you travel around, you talk to doctors. I need medical professionals, neurologists specifically, to not do that. Like, I need them to understand and realize I need that nurse that's there to put their arms around me like the cancer patient and help me and understand. I need that doctor to understand that I have no idea what they've just told me. And that is where it was so frustrating. And even my neurologist that saw me in the hospital said, "Your MS is too bad. I can't help you. You need to go see another MS doctor." I went to Hopkins. That one wasn't willing to put me on the meds I needed. So my primary care finally found me a doctor in Cleveland that was willing to put me on the right meds, talk to me, listen to me, understand the questions. I'm that patient that goes in with the binder and has a million questions. And
just 1 inch? Not 3 inches.
Yeah, just 1 inch.
Okay,
And I'm very organized with those. But I mean, how do we get the doctor, the neurologist, the doctors to understand that they need to treat this disease like they treat cancer patients, like they treat the other diseases?
Well, first of all, I was not implying that people need to be their own advocate at the time that they're diagnosed, because that's impossible. You don't know what you don't know. You have no idea what this is that has been handed to you. Right. So after the newbie stage and you're in the MS family, then you need to be an advocate like you are. You're here being educated. When you're a newbie, you have no idea what you know, what you don't know. You've never even heard of MS, usually, is the case. It's important. You will never ever, it's difficult to change how people behave, whether they have empathy or not, or whether they know when to fill somebody's need. That's when it's important to kind of shop around and find somebody different and find somebody that actually fits your needs. And that's what I was kind of referring to when I was saying people spend a lot more time shopping for a mortgage or a car loan than they do a doc. People think that, this is kind of, they get what they get, and that's not the case. You are the consumer, and it's your job, and that's where support groups are so helpful, or going to meetings like this to hear people's experiences with certain physicians or nurse practitioners or groups, to hear who everybody else sees and what their interactions are like. I think that's incredibly helpful, and I think that's how most people kind of find somebody that they like by networking and talking to other people.
It just sort of seems like there needs to be a shift.
Oh, there needs to be a huge shift in empathy and caring for the patient and not some disease.
Or just explaining it.
That'd be nice too, explaining.
The disease, not just like walking out of the room and like, here you go.
Yes.
Good luck.
I'm with you. I totally agree.
Yeah.
Yes.
I don't really have a question. More,
Then take away the mic.
well, it's an important commentary. Is that I so agree with you when it comes to the label. I was diagnosed a gazillion years ago, thank you. And in 2003, I actually, with the support of my neurologist at the time, to go to Chicago, and I tried to get into a bone marrow transplant study, which is a long story, but the deal was the doc there actually was the first day that somebody verbalized that you're primary progressive. I thought that was the longest, hardest, worst day of my life. And actually it turned out when I came home, I really thought about it. It was probably the best day, simply because that was a label. And I rationalized for now the last 18 years of my life saying that at least I know every day pretty much how I'm going to wake up. It's going to be that slow, steady digress. I'm not going to wake up and have the relapse and remitting issues that the relapse and remitting folks have. So I do think it's a blessing. And I absolutely wholeheartedly agree with the primary progressive is not the end of the world. And it actually does give you a chance to adjust. You can adjust to every single thing that's going to happen. You can plan ahead. So for me, that was a benefit.
Everybody's MS is their MS. You know, and even amongst 10 people who have the label of relapsing remitting MS, everybody's so different. You can't you don't gather any more information about your MS just because you're in a room full of people, 10 other people with relapsing remitting MS or progressive MS. You have your MS. You have, I categorize MS as boring. That's the highest compliment I can give somebody if they're boring. Boring is really, really, really good. Garden variety ups and downs. Interesting. You don't really ever want to be an interesting patient. And if my husband knows about you, you have pretty lousy MS, because that means I talk about you a lot, I bring you home with me, and I'm losing sleep over you. So those are my MS categories. So people sometimes say to me at the end of the appointment, I'm boring, right? I'm boring. Am I so boring? Am I still boring? And I say, you are way boring. And they're very excited to leave, knowing that they are one of my more boring people. So,
I think as an MS patient, the one thing I find frustrating is the criteria by where they call it a relapse. Because it's supposed to last more than 24 hours. I know I have things going on some days that only last 6 or 8 hours. And I know they talk about pseudo relapses and things like that. But I know they're new things, and I think that frustrates me.
sometimes, though, it's not truly a relapse, meaning that it's that there's some new area of inflammation. Sometimes it's from damage that has already occurred, and when you have kind of glitches through glitchy areas, some people have their sine wave is so varied throughout the course of the day. They morph so many times because of stress, body temperature change, amount of sleep that they had, so many different factors. So some people have so much variation throughout the day, and they will say, I have relapses all the time. You don't have relapses all the time. You have this ongoing sine wave of symptoms that needs to be mellowed out. It's not a relapse.
Any other questions? Let's say thank you, Dr. Crayton. You were awesome.
Thank you for the invitation.
I can't wait to show the world this. The world. Thank you.